So, good evening, everyone. Welcome to this wonderful program of Focus, where we start with the basic physics of ultrasonography as well as the nomology. So, before we understand the technique of ultrasonography, we first need to know what it is. So, ultrasonography is basically a technique which uses the echoes of ultrasound pulses, which are produced from a particular transducer to delineate objects or areas of different density in the body.
Dr. Aditya, there is some disturbance.
Am I audible now?
You're audible, but there's a lot of background disturbance.
How about now?
Aditya, please remove
Aditya,
the
you're
headphones.
audible, but there is a disturbance.
Remove the headphones, Aditya, without the headphones, please, if you can. Thank you.
Am I audible now? Is it better?
Yes, better.
Yeah, okay. So ultrasonography basically is a technique which makes use of echoes of ultrasound pulses, which are basically generated from an electrical transducer to deal the objects or areas of different density in the body. Now, an ultrasound is any frequency which is greater than 20,000 hertz, and in diagnostic USG, it ranges from 1 to 30 megahertz. Normal hearing range for a human ear is 20 hertz to 20 kilohertz. Anything above 20 hertz is called infrasound, and anything above 20 kilohertz is called ultrasound. So above 20 hertz is basically they are the low bass notes, and these are typically seen in the trembles of earthquakes. Because human ears are not able to hear this infrasound, we are not able to detect earthquakes early on. But if you know this phenomenon that animals can detect this infrasound, that is why they are the first ones to detect any kind of quake activity. In contrast to that, ultrasound is the frequency more than 20 kilohertz. Again, this goes beyond our normal hearing range. Once we start escalating from 20 kilohertz, it ranges towards the animal hearing, beyond which it goes into the medical therapy, that is around 2 megahertz. And then for medical diagnostics, it is from 2 megahertz to almost 200 megahertz. Medical ultrasonography basically is the use of this ultrasound to make diagnostic imaging techniques. And these high frequency sounds and their echoes are then used to visualize the internal organs. It's a real-time dynamic investigation. Now, coming to the history of ultrasonography. So it was in the mid 19th century that the use of echoes was done. It was first used to measure the distance underwater using sound waves. Later on, this technology was further developed by military and navy to introduce sonar, which is sound navigation and ranging system, which was extensively developed and used in submarines in 1940s during the World War. Thereafter, they thought a lot over this, and then this was also brought into the medical field, where the first successful measurement of heart activity with the ultrasonography was done in 1953. Thereafter, a decade later, the whole study of pregnancy, right from the beginning to the finish, was done, and it was also used to diagnose the complications associated with it. In 1975, this became a two-dimensional and real-time technique with the advancement of technology. And in 1994, we started using 3D ultrasound. Now, sound has two components. It has a wavelength and it has a frequency. So wavelength is basically the distance a single sound wave travels, while the frequency is the number of times that sound wave travels in a particular time frame. So wavelength is always inversely proportional to the frequency. A shorter wavelength will have a high frequency, and a long wavelength will have a low frequency. So the principles involved in ultrasonography. So at any given temperature, the sound velocity remains constant in a given material, but it varies in different materials. So when sound travels from one medium to another medium with which are of different materials, there is a change in the velocity, in the wavelength, as well as the frequency, which then can be measured in the transducer and translated into a visual image. Solid structures usually reflect sound waves, while hollow or soft structures, they don't reflect sound waves. It is transmitted without any interference. And when sound travels from one medium to another, it either changes direction or speed or both of these factors. The basic principles of ultrasonography imaging are very simple. There is a piezoelectric transducer, which is basically excited by electrical energy. And these piezoelectric particles, they vibrate at a particular resonance frequency. And it sends a variable frequency pulse into the target tissue. The echoes received from these tissues are then converted into a radio frequency signal, which is analyzed and shown on the video screen. What is the piezoelectric effect? This is the ability of certain materials to generate an electric charge in response to an applied mechanical stress, which is similar to a piezoelectric quartz crystal. So the basic principle comes from a quartz crystal, which is a kind of a soft rock, and it has the propensity to vibrate at a particular frequency when stimulated. The brightness of a particular tissue or an image is a function of the ultrasound wave, which are reflected back to the transducer, which happens at the interface of two tissues or two surfaces with different physical properties. So like in this image downstairs, so from the transducer, there is a piezoelectric crystal which is emitting ultrasound waves, which are going and hitting the particular tissue. Say in this, it is the kidney. Now, kidney being a solid organ, it reflects back these sound waves, which are called echoes, which are then hit on the transducer itself, and it produces a image on the ultrasound screen. So, ultrasound transducer basically is made up of an acoustic lens followed by a matching layer, then a layer of piezoelectric crystals, a backing layer, and acoustic insulation so that the frequency remains constant. And these piezoelectric crystals are then stimulated by electric current and converted into ultrasound waves. The arrangement of piezoelectric crystals is fixed in particular transducers. Now, for any ultrasound probe, like we've already seen, high frequency has low wavelength. So it gives you a better resolution, but it does not reach a particular depth. So your depth perception is less for high frequency, and hence it is best used for superficial structures. While the probe which has a low frequency, it will give you a poor resolution, but it can travel furthermore down into the tissues. Hence it is best for deep structure visualization. Any structure which is more than 6 centimeters in the depth, you always choose a low frequency probe to have a better visualization. And there are 3 types of probes: curvilinear, phased array or a cardiac probe, and a linear probe. So difference between the 3 transducers is as follows. In a phased array or a cardiac probe, the frequency ranges from 1 to 5 megahertz and can detect up to a depth of 35 centimeters. In a curvilinear one, the frequency is 2 to 5 millihertz and the depth is 30 centimeters, while a linear probe will have a frequency of 5 to 10 megahertz, but the depth will be around 9 centimeters. So basically, that is why linear probes are best used for your vascular visualization, for invasive lines, while curvilinear probe is most useful for abdominal structure demonstrations, and phased array is used for cardiac visualization. So this is basically a ultrasonography machine, which consists of your screen, your basic array of buttons, which control all the functions, your different probes. Now, how does this ultrasound transducer create an image? Now, the image formation is dependent on 5 properties of the tissues. Either it can reflect the ultrasound waves, it can refract it. Refract means basically change in direction. It can either absorb or attenuate it. It can either disperse it. It can either diverse it. So it is called a divergence. So in all these phenomena, there is either a change in your direction, change in velocity, or both. Now, depending upon the response of the tissues, they may appear as one of the four shadows. So an isoechoic shadow is the same echogenicity as the surrounding, which usually appears as gray. A hypoechoic region is a region which has less echogenicity than the surrounding areas. So it is gray to black, grayer than the isoechoic shadows. Anechoic shadows have no shadows, that is absence of shadows. So they appear black or completely dark, like air or water. And there can be hyperechoic images which are more echogenic than the surroundings. So they are more whiter or brighter. So bones, any calcific stones, calcific structures will appear as white or hyperechoic. Coming to the nomology. So this image basically shows you the basic array tree of any ultrasound machine. So it is very important to know what each of the buttons or knobs does, because the primary image may not be the particular thing that we're looking for. We may have to modulate a little bit so that the target tissue or the target measurements can be done. Older machines we had buttons. Nowadays, touchscreen technology is also available. So usually, these are the important buttons or knobs which are used on a USG machine. The first and foremost is your power on-off button. Thereafter, you have a transducer selection button. In that, you can also have a preset of imaging modalities. Then there's depth adjustment knob. Then there's a focus knob, an overall gain knob, and some machines will have a time gain or selective gain knobs, which if you see on this screen is on the top half right side. Then there's a freeze button. You can have a frequency button to change the frequencies. Then you have M mode measurement. You have color Doppler, spectral Doppler, and power Doppler buttons. You have a M mode button. In the end, you have a print or save button. What are the major imaging modalities which can be used on an ultrasonography machine? So there are four basic modes. B mode, which is basically puts focus on the brightness. M mode, which focuses on the motion. Doppler mode, which includes color Doppler, spectral Doppler, and power Doppler, which will be explained in the later slides. And the amplitude mode. What is this B mode? B is basically denoting a brightness mode. It is also called a 2D mode. So basically, it uses the grayscale imaging in an ultrasound to render a two-dimensional image in which the organs and tissues of interest will be depicted as points of variable brightness, which are termed as isoechoic, anechoic, hyperechoic, or hypoechoic. The formation of the particular image of the tissue depends on the pulse echo principle. That is, assuming that the speed of sound remains constant, the position of the target of interest may be inferred by the time taken from emission of this ultrasound wave to its return to the transducer. And the amplitude of the returning ultrasound wave is depicted as a function of brightness. Hence, this mode is called as a brightness mode or a P mode. As in contrast to a B mode, which is kind of static, M mode is a motion mode in which a motion is displayed over time. So a single 2D image is displayed over a determined length of time, and the time sweep can be adjusted and measured. This is often utilized because of its axial and temporal resolution for structures, and is a form of ultrasonography mode in which a single scan line is emitted, received, and displayed graphically. So a particular section of a tissue or a section of the image obtained on the USG screen can be targeted to measure the motion. So an M mode recording is conventionally displayed with the Abisca representing the time and the ordinate showing the distance from the transducer, with the latter derived from the time delay from the echo emission from the transducer to the reflection and detection of the waves. So the temporal resolution is the most useful in delineating the path of structures which are moving at high velocities when considered according to the time. That is, for example, when we take a cardiac cycle, so the movement of a particular valve or a particular myocardial valve can be taken into consideration, and it can be graphed over time to see the activity or the motion over it, and particular measurements can be done. The axial resolution is also important in echocardiography, as it allows the resolution of very delicate cardiac structures like the wall leaflets, which are difficult to resolve, especially with the transthoracic echography. It is an excellent modality for lung ultrasonography as well as for echocardiography. Now coming to the Doppler mode. So what is basically a Doppler? So Doppler mode depends on the Doppler shift. The basic principle is a Doppler shift, in which as compared to a static object, this takes into consideration a moving object. So basically consider a blood vessel in which your erythrocytes are moving in a particular direction. So when the transducer is emitting an ultrasonographic wave towards the blood vessels, these erythrocytes will be reflecting those waves. But because they are not dynamic, they are dynamic, they are moving in a particular direction. So the Doppler shift happens because the wave frequency alters with the time. So it is basically Doppler shift is calculated based on the transmitted frequency and the received frequency. So it is the difference between the two, and it is dependent on the velocity of the blood, the angle between the ultrasound beam and the direction of the blood flow, and the velocity of sound in that particular tissue. So ideally, the best way to have the Doppler effect is when you're in when your angle is 0, that is you're in line with the vascular structure. If you're at 90 degree or perpendicular to the vasculature, then you will have a minimal Doppler shift, because the function of Doppler shift depends on the cos of angle. So cos 0 is 1, which causes a maximum Doppler effect, and cos 90 will be 0, which causes minimum Doppler shift. So if you can see on the left side image, the top image is showing the erythrocyte which is going towards the transducer. So because of that, when the transducer first frequency is falling on the erythrocyte is moving towards the transducer. So the distance between the two is becoming less. So the reflected wave will be shorter than the transmitted wave, and that is why it will emit a particular color on the ultrasonography screen based on the Doppler shift effect. As contrast to that, the second image shows that the erythrocyte is moving away from the probe. So a transmitted wave is shorter than the reflected wave because the distance between the erythrocyte and the transducer is increasing. That is why it emits a low frequency wave. Now, what is color Doppler? So color Doppler basically illustrates the direction and velocity of flow within a user-defined field of view. So whenever there are brighter pixels, it indicates a higher flow, while darker pixels will show slower flows. And this can be adjusted according to the scale and field of view. Now, color Doppler is a very useful modality to interrogate organs for the presence or absence of blood flow and quickly investigate a large area for turbulent flows. In case of cardiac imaging, it is basically used for valvular lesions, where you can quantify and qualify the regurgitant and turbulent flows. So if you can see in the B mode, you will just visualize the hyperechoic and the hypoechoic lesions. But as soon as you put in the color flow, you will have color modalities in your vascular structure. Now, always remember, there's a very small mnemonic called as BART. So anything which is showing blue, the blood flow or the flow in that particular vessel will be away from the transducer, while a color red will indicate that the flow is towards the transducer. It does not mean that it is an artery or a vein. Red means artery and blue means veins is not the nomenclature over here. It just denotes the direction of flow. So if you see in the above image, you have two vessels which are showing red discoloration and one of them is blue. So in these two red vessels, the blood flow is towards the transducer, while in the blue demarcated vessel, the blood flow is away from the probe. And whenever there is a regurgitant flow, you will have a mosaic kind of a pattern in which you can have different colors across the regurgitant structure because of turbulence. Coupled with the color Doppler is the next mode, which is called as the power Doppler. So this is a technique which basically uses the amplitude of Doppler signal to detect moving matter. And this is independent of velocity and direction of flow as compared to color Doppler. So the possibility of any signal aliasing is reduced to a minimum. Now this focuses only to display the amplitude or the strength of the Doppler signal. Being independent of angle, it allows the detection of smaller velocities than the color Doppler and facilitates the examination of certain technically challenging clinical settings, such as in cases of tumors. It has a higher sensitivity than a usual color Doppler, which makes it a trade-off with flash artifacts. It is particularly useful in examining superficial structures such as the thyroid gland, the testes, the renal grafts, and with the subcutaneous tissues. It is also made use of to look for any tumor vessels, to evaluate any tiny low flow vessels which cannot be evaluated on color Doppler or can be missed out on color Doppler, and to detect very subtle ischemic areas. It is less affected by the Doppler angle and therefore detect flow that may be close to perpendicular to the ultrasound beam as compared to color Doppler, which does not give you a good image on when you are perpendicular to a vascular structure. Additionally, when we increase the gain, the low amplitude noise in the surrounding tissue is more easily filtered out. So all your signal aliasing and artifacts are filtered out, which thus increases the sensitivity of power Doppler for detecting blood flow in very low flow states. So if you see in the lower image, a normal color Doppler will show you red and blue imagings, but it will not tell you the complete picture. And this will be detected only when the flow is above a particular velocity. While a power Doppler of the same tissue is showing you a much higher vascularity, but it does not let you know in which direction the flow is. It only lets you know that this is a particular vascularity or the number of vessels in this particular region is more. It is usually displayed by orange color. What is a pulse wave Doppler? In pulse wave Doppler, the user basically defines a very small area, which is called a sample volume or a gate within the B mode image. And based on the pulse repetition frequency, the time required the sound waves to return, only the Doppler shifts from that area are recorded. The major advantage of this Doppler is to specify where along the Doppler line, it shows an ability to measure velocities. This is possible because the pulse wave sends and analyzes sound waves sequentially. And in this modality, the machine is programmed to ignore all the signals. So all aliasing is negated, except for those that are reflected from a certain depth. So you basically can target a particular slice of a tissue for your measurements. So if you see in this, the pulse wave Doppler is kept on a particular vessel. Now, because it is a two-dimensional image, it is difficult to realize which vessel it is. But as soon as you put the power Doppler mode into it, you come to realize that along with the color Doppler, it will also give you a sound wave Doppler, which will indicate whether the flow in a particular vessel is arterial or it is a venous one, based on the sound waveforms as well as the visualization. So it is basically a correlation of your receive frequencies. Now, whenever you have a USG machine with you. How do you proceed ahead when you're using it on a patient? The first and foremost thing is plug it in, power it on, let the basic screen come on in. Then, based on what you want to examine, you have to select the probe. Once the probe is selected, newer machines will also have presets, whether with a linear probe you want to access the vascular structures or the superficial organs or anything. Then once you've kept the probe on the patient to visualize a particular tissue, now you have to adjust the depth to see till which that you have to basically visualize your organ. So here comes the use of your knobology, wherein you can use the depth knob to detect the length of screen that you want to. Then you can have the control over your gain, in which you can have a selective gain or you can have an overall gain to visualize your structure better. Then you can have a freeze or a save mode, wherein on a static image you can have your measurements. You can also have dynamic measurements, and then you have to correlate all these things. So almost all the UHG ultrasonic waves, they are reflected at a metal or air interface. And that is why it is important to use a coupling gel whenever you're going for sonography examination, because the transmission through a coupling medium, it negates all the reflected waves which happen due to air interface. The coupling medium allows the transmission through it to allow better visualization at the interface. And during USG assisted invasive procedures, always remember to cover the probes with a sterile sheet to maintain asepsis as well as to protect the probe from contamination. Now, each of these probes will also have a orientation or indicator mark, which lets you know the direction in which you have to put the probe in, and in relation to the patient. So it can have a coronal or a caudal or a left or right orientation based on the marker. Now, to understand the orientation and interpretation of your visual fields, they are usually divided into planes. So you have a coronal plane, you have a transverse plane, and a sagittal plane. Now, all your probe placements are according to these planes, so that when you have a visual image on your ultrasonography screen, you know which structure you are looking at, and you have a because you have a two-dimensional image. If you know your planes in which you have kept your probe, it is easier for you to determine the directions. Sorry. Now, gain is basically the strength of the returning echoes, which over the screen will give you the image of your tissue. Now, there can be a overall gain in which all the structures will be brightened out, or you can have a top or a bottom half or overall gain adjustment, so that in a particular screen you can focus over the upper half of the field, or you can focus on the lower half of the field. So in these images, as you can see, your upper half is undergained. That is where the lower field structures are visualized better. And in the lower image, the lower half of the image is underfield, and that is where the upper structures are better visualized. Now, what are the artifacts? So whenever a sound encounters a high attenuating tissue, the echoes are diminished posteriorly, and an acoustic shadow results, which can be seen on the USG monitor, usually as a black shadow. When the sound encounters low attenuating tissues, the echoes are enhanced posteriorly. This principle may be used as a window to visualize the anatomy. While when the sound encounters air, much of the signal is lost to scatter, obstructing the visualization of the anatomy posteriorly. Now, there are three other phenomena, which is called refraction, which appears at the edge of an artifact when the sound crosses a boundary between the tissues with different propagation speeds. There can be reverberations, which appear as bright arcs at equidistant intervals from the transducer. and a mirror effect, which basically is when the sound glances off the tissues, like diaphragm returning to the probe with a longer time of flight, for which the machine misinterprets this as more of a liver tissue. Whenever you have a image acquisition, you need to know a few basics, what you need to see on that image. So first of all, you need to know which anatomy you're looking at. You have to visualize that anatomy on the screen. You have to define the boundaries with the use of your depth, your orientation scales, which can be done with the use of a proper transducer. You need to know and learn your acoustic windows, and then you maximize your system control. As with any other machine, your USG machine also needs to be cared and handled properly. You should always clean the machine and the probe with a clean soft or with a tissue paper. Never use a alcohol or a commercial cleaner, because this interferes with the piezoelectric effect of the transducer probe. Never drop the probe or run over the cords or park the machine in a traffic area, so that unnecessary physical damage can be prevented. And these piezoelectric particles are very prone to physical injury, and damage due to fall of the probe may need to be completely replaced with a new probe or even a new machine. And all these things are very expensive to replace. The benefits and risks, because there are no ionizing radiations, so this is the best modality to visualize any of the structures. It is non-invasive, it is painless, it is easy to use, it is less expensive as compared to CT and MRI, and it is a real-time imaging, and can be done bedside also. There aren't any adverse biological effects that has been yet observed, but because it's an operator or observer skill dependent, hence there can be variable results. It doesn't pass through air or gas, and can be reflected, and hence can have a limited evaluation of hollow structures. It does not penetrate bone, and hence it can visualize only the outer surface. No internal structures inside the bone can be visualized. Now it has multiple diagnostic applications, the most common being echocardiogram, wherein you evaluate the heart structure as well as functional integrity, the walls, the valvular structures, the flows across the walls, any abnormalities in that, and all the gradients can be measured. In obstetrics, it can be used for the follow-up of the development of the fetus. In abdominal, it is useful to detect structure and functional abnormalities of abdominal organs. In the renal system, it examines the kidney and the urinary tract, as well as it can be used in post-transplant also, wherein you can visualize the vascularity of the new transplanted kidney. And it can also be used to examine the vascular structures, to give the integrity and functionality of the vascular structure, detection of blood clots, as well as insertion of cannulas, which is most commonly done in the ICUs. Thank you.
Nice
Thank you very
presentation, Aditya. Thank you.
Thank you very much, Dr. Aditya, Dr. Apurva. Next, I welcome Dr. Tushar Parmar for moderating the session. Dr. Tushar is Additional Director in Critical Care in Reliance Foundation Hospital. He is also the in charge of EMS services in Reliance Foundation Hospital. He is known for his great clinical and organizational skills. I welcome Dr. Tushar, and I request him to please introduce Dr. Vivek Jain.
Thanks for the introduction. Dr. Vivek is an extremely talented colleague of mine, and we have been working since last 2 years together. I would like to introduce Dr. Vivek for the next talk, where we are going to talk about trauma, indications of ultrasonography, and what are the ways we can help out the patient. Why in trauma? Because in trauma, we understand that there would be a definite need of, I would say, directly going towards an diagnostic as well as therapeutic approach both. Timely, a good images and good sonography will save lives at this point of time. And I understand there is no other better person than Dr. Vivek to explain that. And over to you, Dr. Vivek. Please take over the session.
Thank you, sir. Thank you very much. Good evening. So my slide is visible.
Yes, it is.
So I'll start, sir. So we'll start with ultrasonography in trauma. Whenever we do ultrasound in trauma, it means that we are doing a protocol which is called as FAST protocol, that is focused assess sonography in trauma. And recently it has got one addition called extended FAST, in which we image the lung field as well. It is an extremely important tool in our emergency department because it has actually proven to be a mortality benefit. Okay, now we will go through history before we start with lecture. So in history, in 1960s, for imaging, for as a diagnostic modality, we had a diagnostic peritoneal lavage, which has its own benefits and disadvantages as well. The disadvantages of that, we will not go into the detail how diagnostic peritoneal lavage was done. I'll just give you the disadvantages. It was an invasive procedure which was performed. It was contraindicated in specific population, for example, in pregnant lady. And the lavage fluid may interfere with subsequent imaging. And in some studies, it has been shown that it may lead to high non-therapeutic laparotomy rate. So but the most important part, which is still can be considered to use DPL, it is more sensitive. It is the most sensitive modality we have till date because it can detect as less as 20 ml of blood in the peritoneal cavity. Right. So because of its own shortcomings, in 1980s, it was felt that we should have some other modality for diagnostic. So we went for a CT scan. Now the problem with CT scan was, of course, it has a radiation problem. We cannot shift unstable patient to CT suite. Yes. Screen is not visible, sir. Tushar, sir?
It is visible.
It is visible.
Visible. Visible. So thank you, sir. So, okay, so this CT scan was done, but because we have to shift the unstable patient to CT scan, which was risky, so again there was a need for some or other modality which can be used on bedside. So here we come superhero sonography. Sonography is an excellent tool because all advantages of DPL and CT scan are combined in the sonography and disadvantages can be avoided. Of course, it is not as sensitive as those two parameters like CT and DPL. DPL can detect as less as 20 ml of blood. CT can detect 100 ml of blood, and sonography, depending upon the size of the body, it can detect around 200 to 600 ml of blood. But still, sonography is a gold standard when it comes to bedside imaging of evaluation of the trauma patient. Okay. Now, in trauma patient, sonography is used to detect intraperitoneal injury and thoracic injury. In intraperitoneal injury, the liver is the most common one, spleen in blunt trauma, pelvis and bowel in penetrating trauma. These are the most common organs which are involved in intraperitoneal injury. Okay, the one thought process behind using this FAST is whenever a trauma happens, the blood has a tendency to accumulate in the most dependent position of our body, in supine position. So which is the most dependent position? The first position is the right upper quadrant position, which is described in FAST examination, and it is present below the liver capsule and above the right kidney. Okay, which is also called as Morrison's space, right? This is the first space where this is the most dependent position of the body in the supine position where the blood get accumulated, right? And the second most dependent position is the pelvis position, which is also called as rectovesical pouch in male and rectouterine pouch in female, or pouch of Douglas. Okay, now what do we actually look in thoracic injury? In thoracic injury, we have to exclude tension pneumothorax, hemopericardium, and hemothorax. Okay, now, what are the components of EFAST? EFAST is nothing but stands for Extended Focus Assessment of Sonography in Trauma. The first, what I do is I generally first scan right upper quadrant, then I go to pelvis, then I scan for left upper quadrant, then the subcostal view for cardiology, and then we scan for lungs. Okay. Now, which probe do we use to scan intraperitoneal injury? If the patient is heavy, large, we can use a curvilinear probe, but normal bent Indian people, we can also use a phased array probe. Okay, the first step, as I mentioned, we scan the right upper quadrant portion, that is the Morrison's pouch, with the help of curvilinear probe. Now, how it is done, where is the probe kept, that all will be taken in the hands-on when you come to our hospital. Okay, now what do we see? We generally target this portion of the injury, that is, as I said, between the liver and the right kidney. Okay, and what do we see in hepatorenal pouch? What do we see? What we have to see? We have to see the four things: Morrison's pouch, the caudal portion of the liver, the subphrenic space, and the pleural space. These are the four things which we have to see when we screen the hepatorenal pouch. Now, this is the Morrison's pouch, which is present in between the liver and the kidney. Now, and this is the caudal portion of the liver, which we are supposed to see. Sometime what happened that we may not get the free fluid present in the Morrison's pouch, but if we extend our study to the left part of the liver, then we may get a fast positive. So this portion is also to be screened. The third portion is the subphrenic space, and the fourth is the pleural space. So this is the CT image which shows the target area of our right upper quadrant portion, which we have to analyze. Okay, now this is the portion. This is fast positive patient which came to us with penetrating trauma, and when we scanned him, we found that there is an anechoic space which is present in between kidney. This is kidney and this is the liver, so it was fast positive. Now in the second patient, we didn't get any fluid in between the Morrison's pouch, but when we traced our liver to the caudal portion, this is the fluid which we got, that anechoic fluid. So the patient was taken to OR immediately. So that is the importance of screening the caudal tip of the liver as well, which is generally missed by us. Okay, and this is the subphrenic space which shows fast positive. Now, the best part of the imaging right upper quadrant is it is a huge space, and even when the injury is in left upper quadrant, the fluid may still travel to the right upper quadrant region and you will get fast positive. So we can have right upper quadrant positive in splenic injury as well. How? That we will look further. So our second step is to screen left upper quadrant region. Now left upper quadrant region, same, we have to see the splenorenal space that is in between the spleen and the kidney. The second, we have to visualize the caudal portion of the spleen, and the third, we have to analyze the subphrenic space, and the fourth is of course the left pleural space. Okay, now we will see some example how the anechoic fluid is present in the left upper quadrant region. So this is a CT imaging which shows our target area of interest for the left upper quadrant region. Now this is the image which shows that the fast is positive anechoic fluid which is present in between kidney and spleen. Okay, now this is the image which shows that the caudal portion of the spleen has a anechoic fluid which is again turning out to be a fast positive. Now, the peculiar part of the left upper quadrant is naturally we have got one ligament which is called as phrenicocholic ligament. Now, what happened? Suppose in trauma, if the spleen is shattered and patient is in supine position for some time, then the fluid may get accumulate to the right upper quadrant region, and it will give negative left upper quadrant and positive right upper quadrant region. Okay, and this phrenicocholic ligament also inhibits that same fluid to go down to the left side. Okay, so left upper quadrant is not as sensitive as right upper quadrant screening, but it is highly specific. If you get free fluid in the left upper quadrant, that means FAST is positive. The third area of interest is pelvis region. Now in pelvis, we have we should use probe in sagittal position as well as in transverse position. We will acquire images different in males and female. So first, we will acquire image in male in sagittal portion of the sonography probe. So when we put a probe, we will see urinary bladder. This is the urinary bladder. This is our rectum, and the space between urinary bladder and rectum is rectovesical space, which is our area of interest. Right now, the probe. One second. Okay. So yeah. So rectovesical pouch. Huh? So when you put a sonography probe in sagittal portion, and if there is a free fluid in the pelvis, you will see urinary bladder, the bowels, and this is the free fluid which is present in the pelvis. Okay. The third is rectouterine pouch in female. If the fluid is present, suppose this is the bladder of the patient, this is the cervix, bladder, cervix, this is and this is the fluid which is present, anechoic fluid which is present in the pelvis, which is suggestive of FAST positive. Now, the position of the probe in pelvis cavity is extremely important. How we will see? Suppose one second. Suppose if you keep your USG probe in this direction, inclining towards this direction, then you are actually not targeting the free fluid in the peritoneum. You are in extraperitoneal region. So you may not be able to detect the fluid. But as soon as you incline your probe in transfer and thoda incline towards the head, you may actually get a free fluid inside the pelvis. So if your probe direction is not proper, you may actually miss the free fluid in the pelvis. Now, the fourth portion, the fourth interest is the subcostal view. In subcostal view, what do we actually see? In subcostal view, the main interest is to visualize the free right ventricular wall and the right atrium. Why? What are we supposed to exclude by looking this image? We have to exclude hemopericardium, right? Hemopericardium causing cardiac tamponade. What is cardiac tamponade? That is diastolic collapse of free right ventricular wall. So when you put your probe in subcostal view, the images will travel through the right lobe, left lobe of the liver, and will direct towards the right ventricular wall. Now, this is the image which is showing hemopericardium. Now, even as less as 50 ml of fluid which gets accumulated in the pericardial cavity can cause cardiac tamponade, as opposed to chronic pericardial effusion, which can be as long as 200 to 300 fluid, which will not be able to cause the cardiac tamponade. So acuity of accumulation of fluid is most important parameter causing cardiac tamponade. Then that can be excluded using the subcostal view. Okay, now the fifth portion, fifth interest is lung. What do we have excluding the lung is pneumothorax, hemothorax, right? Now, for imaging lung, we use a linear probe, and sometimes a phased array probe can also be used. People have used a phased array probe for entire EFAST examination as well. Okay. Now, where do we have to keep the linear probe? First, we have to keep, basically we have to image bilaterally. So when the first position is below the mid clavicular line, just below the mid clavicular line. The second position is you have to keep the probe just above the nipple. The third is you have to keep in the anterior mid axillary line in the fourth intercostal space, and the fourth is fifth intercostal space in the mid axillary line. Okay. You have to make sure that you see the pleura when you do the lung ultrasound. So this is the image when we acquire while doing lung ultrasound. These are two ribs. Okay, this is skin, subcutaneous tissue, and this bright silver line is our pleural line, which is the area of interest. I will tell you how. Now, in pneumothorax, what happened in normal patient? First, we will see what happens in normal patient, right? So, yeah, on your left side of the screen, we are doing lung ultrasound and shows this pleura is sliding. The visceral pleura and the parietal pleura is sliding on each other. That means it is normal. These are the ribs, right? Now we will visualize how does in pneumothorax they get affected. So in pneumothorax, the visceral pleura and parietal pleura will not be able to move on each other. You will see that they are moving, but they're actually not. The ribs are moving. That is why you feel that the pleural line is also moving. Now, in case if you are unsure that whether it is pneumothorax or not, you can always put an M mode on the area of interest, right? And when you put an M mode, yeah, so when you put an M mode, you will see, so in normal we see a seashore pattern. This is the sea and this is the shore. In case of pneumothorax, we see a barcode or stratosphere sign, which is this. This is the barcode. The entire M mode will show horizontal lines and absence of grainy appearance. Okay. So whenever you feel that this is a pneumothorax, you just put the M mode and you will get this sign. Okay. The second thing when we have to exclude doing is a hemothorax in the lung ultrasound. So before we actually go to visualizing a hemothorax, we should know what is a mirror artifact. Now mirror artifact is something when you keep a probe, and as we know that diaphragm is very reflective surface and air is a poor conductor of sonic waves. The entire liver, this is the liver, this is the diaphragm, and these are our lungs. So entire liver gets mirror image on the lung. This artifact you have to keep in mind when you visualize the lung for hemothorax. Okay? How does hemothorax look? Hemothorax. Okay. So this is liver. Okay, this is diaphragm, and this anechoic structure is our hemothorax. Now, what are these? These are spine, and so whenever hemothorax is present, you can also see a thing called as spine sign, which is also present. Okay, in pneumothorax, yes, spine sign is done. So this is normal, and this is hemothorax. Now, so if your fast test is positive and patient is stable enough, so you can transfer it to CT scan to get a more detailed examination about the injury. And if the patient is unstable and fast is positive, then the patient directly goes for some or other kind of procedure. For example, he may go to operation theater for diagnostic laparoscopy or laparotomy, or he can go to interventional radiology for embolization of blood vessel, or we can get a chest tube insertion, whatever, right? Now, if the fast is negative and patient is stable, in that case, what you do is you repeat the scan, you repeat the fast scan every 15 minutes, because we know that fast is not as sensitive as CT or DPL. So you repeat the scan, or you can take the patient to CT scan. Now, what happened if fast is negative and patient is unstable? In that case, it comes into sort of gray area, you can seek for extra abdominal source. For example, like long bone fracture, you can go for DPL, or you can transfer patient to OR if you are unsure. So this portion of fast scan is thoda in gray area. What not we don't have clear-cut guidelines about what to do if the fast scan is negative and patient is unstable. So in that case, you have to find the etiology, and at the same time, you have to take the patient to OR. Right. Now, this was everything about fast scan. And of course, we have lots of advantages of doing eFast in our trauma setting, but there are some pitfalls which we will go through. The first pitfall is the fast scan doesn't include the visualization of inferior vena cava. Now, for visualizing, we have subcostal view, which is included in the fast scan to exclude hemopericardium. Now, in the same setting, if we tilt that probe slightly towards right, we will be able to see IVC. Now, why IVC is so important in trauma setting? First, it can roughly get us idea about resuscitation. And second, it can actually support our diagnosis of obstructive shock like a tension pneumothorax or hemopericardium in which IVC is dilated. Right. So since we are doing subcostal view, we might as well do for IVC as well, but this is not included in the eFast protocol. The second problem with fast scan, as we have also discussed, that if the patient is borderline stable or stable and we are not getting any etiology, we are not able to find any free fluid in the abdomen. So in that case, we have to repeat scan every 15 minutes till we get some etiology. So this is one of the shortcoming in which we can take actually help of our CT scan. Third, in some cases, you can also find right upper quadrant free fluid false positive when you actually don't have fluid in the abdomen. Now, what are those cases? Suppose if the gallbladder is unusually high in some normal people, you may get this free fluid in between kidney and liver. The differential is this kind of free fluid will be slightly pointy. Now, I have not seen it, but it is mentioned in literature. So you should be aware that right upper quadrant false positive in large gallbladder. Right. As we have also discussed, the left upper quadrant is not very sensitive. Now, this was a real case in which this is the spleen, which is shattered, almost type 4 injury, type 4, type 5 injury, and still the left upper quadrant isn't showing any free fluid. So, as we have also discussed, it is not sensitive because of the phrenicocholic ligament. So you have to keep watch that if the patient is unstable and the left upper quadrant is not showing anything, then we should go for CT scan or OR. Right. Now, what about subcutaneous air? Suppose if there's a subcutaneous air and you put your linear probe on this subcutaneous air to visualize the pneumothorax, you will actually find that the visceral pleura and parietal pleura is not moving because this is confounded by presence of subcutaneous air. Now, there is almost always a case that if there is a subcutaneous air, there should be pneumothorax, but it is not always true, right? So even if the patient doesn't have pneumothorax, you will falsely diagnose it as a pneumothorax if there's a presence of subcutaneous air. Right? So this is normal patient, and this is the subcutaneous air which is present. Now, what about the ascites? So this is the patient, for example, a chronic liver disease with ascites, presence to the trauma patient, presence to the emergency with road traffic accident. You will not be able to explain whether this fluid is ascites or a blood, right? So in that case, what you can do is you can stick a needle inside the tummy and aspirate it and find it whether the fluid is ascites or blood. Now, sometimes you can also get a non-hemorrhagic fluid in the intraperitoneal compartment, which is giving the false positive fast. For example, a ruptured urinary bladder, a ruptured bowel, or ruptured huge cyst inside the liver or kidney can cause free fluids in the abdomen as well. Right. Lastly, multiple. You should always try to acquire multiple view. One view is a no view. With one view, you can actually sometime diagnose falsely. So when you want to confirm your diagnosis, always try to get an other view as well. I think we are done, Tushar sir.
Yes, thank you, Vivek, for good view of whatever has been required in trauma. So whatever Dr. Vivek has explained, I think so that has been the gold standard nowadays. And coming to a conclusion that FAST and eFAST are the primary protocols of trauma, and being master in that will help you out to actually save lives. Thank you, Dr. Vivek. I'll again get back to Dr. Vikrant for the
Thank you, sir.
for the next session to begin. Thank you. Thank you, Dr. Vivek.
Thank you, Dr. Vivek and Dr. Tushar. That was indeed a visually delightful session. I now welcome Dr. Mehul. He's our Chief Intensivist in Reliance Foundation Hospital. Other than clinical excellence, research is his core area of interest. I request Dr. Mehul to please introduce Dr. K. Subbareddy.
Hi, good evening, everyone, and thanks to the organizers. And I think, Vivek, your talk was excellent. I think Dr. K. Reddy does not require an introduction. He is very well known. He's been the medical director at the Apollo Hospital at Hyderabad. He has been having keen interest in neurocritical care, neuroanesthesia, cardiac anesthesia. And he's going to take us across to an important topic, which is on ultrasound in approach in raised ICP. And I feel that that is something like in trauma. Ultrasound has changed a lot of things for the ER team and the ICU team. And these are important skills and important lectures that we all must know. I guess after he lays the foundation, the workshop on this would be much more simpler. I hand the mic over to Dr. Reddy.
Thank you so much, Dr. Mehul, for that kind introduction. I hope I am audible. So, yeah, I'm going to share my...
Yes, you're audible, sir.
Yeah. And let me thank H&R Reliance Hospitals, Dr. Mehul, Dr. Rahul Pandit, Dr. Arindam Kaur for inviting me for this. I am going to talk about sonographic approach for the intracranial pressure raised ICP monitoring. I'm trying to share my slides. Can you see my slides?
Yeah, we can see it. We can.
Yeah. Where is the one? Yeah. So good evening, all. I'm going to talk about sonographic approach in a patient with raised intracranial pressures. We know the intracranial pressure monitoring is like a traditional in ICP monitoring. It's cumbersome in the intensive care units. More than cumbersome, it has got it leads to a lot of complications when you have an intraventricular catheter. We have various methods of monitoring ICP, subdural bolts. And then we have intraventricular catheters. And then because of the increase in gram-negative multidrug resistant infections, keeping these intraventricular catheters is leading to multidrug resistant gram-negative meningitis, which is very difficult to treat and the mortality increases. So because of ultrasound now, we got we are moving away from this invasive ICP monitoring, and then we are going towards non-invasive ICP monitoring modalities. And these are, and then we will look into the literature whether the sensitivity of these like a sonographic approaches for the raised ICP. With this introduction, I'll be moving to my slides. Henry Marsh, some people may be knowing, he's one of the very popular neurosurgeons, and then he's specialized in, his special interest is in awake craniotomies and ICP monitoring. And he says, the eyes are said by poets to be the windows to the soul, but they are also windows to the brain. Examining the retina gives a good idea of the state of brain as it is directly connected to it. So we use basically eyes to insunate, and then look at the optic nerve sheath diameter as one of the modalities to measure ICP in the intensive care unit. So as I told, the eye is the corridor to the brain. The optic nerve is covered by a leptomeningeal sheath, which is easily expandable in the anterior segment behind the globe. So when the ICP rises, the CSF is pushed towards a tiny rim of the subarachnoid space between the sheath and the nerve, causing the expansion of the dural covering. So that's why we take the anterior part, and from where to measure also we will see. And these changes are more marked in the anterior part of the nerve sheath behind the globe. So this is the most sensitive part to measure the ICP. So there are various methods to find out through ultrasound in raised ICP, like we can look at the pupillary reflexes. But if there is any eye trauma, like we were discussing about FAST in trauma, like when you get a trauma patient and both eyes are swollen, or there are there is a hematoma, and then they're not able to open their eye, and we can use ultrasound for monitoring the pupillary reflexes. And then we have now optic nerve sheath ultrasound that is ONSUS, and then we can look at the midline shift by using ultrasound, and we can look at the pulsatility index if you have a transcranial Doppler mission, which all of us, we know how to monitor the pulsatility index. And then in head injury, it's a very important tool, the transcranial Doppler. You can look at the pulsatility index, and then you can say whether there is raised ICP or not. And depending on the pulsatility index, the value. And then why the ICP is rising in a traumatic brain injury? Is it because of the hypoperfusion, or is it because of the hyperemia? And then basically in the transcranial Doppler, you will be measuring the velocities, and then it is easy to find out the pulsatility index, and then to monitor the raised intracranial pressures by using pulsatility index, especially in head injury, is very useful. And then again, by using transcranial Doppler in a head injury patient, if the ICP increases, and then we can, with the TCD, we can even diagnose brain death, and then we can use transcranial Doppler as an ancillary test for diagnosing brain death.
So we will look at how we will use the ultrasound to pupillary for pupillary examination. So now we have a patient of a trauma, and where one eye is so much edematous and swollen that he cannot open the eye, and then the light cannot be shown onto the eye because we cannot open the eye. So here we can look for the consensual light reflex. So we can monitor the light reflex in the eye, which has been normal, and then we can use the consensual light reflex, and with the ultrasound we can see if the pupil is constricting or dilating. So we use the B mode ultrasound, and then we can, after the cross section through the iris, we can take it, and the ultrasound can be placed either on the above the eyelid or just below the eyelid also. And once the pupil is in frame, then we can use the M mode to look for the constriction of the pupil is happening or not. And also we can, if the consensual light reflex is not possible, then we can at least look for the pupillary asymmetry. Now, as we have discussed how the optic nerve sheath diameter expands with the with the rise in the ICP, when there is increase in the CSF pressure through the subarachnoid space between the optic nerve sheath as well as the optic nerve, then there is increase in the optic nerve sheath diameter. The usual diameter is around 4 millimeters. So once the diastolic intracranial pressure increases more than 13 to 14 mm of Hg, that is when optic nerve sheath starts to expand. And beyond this point, there has been a linear correlation between the enlargement of the optic nerve sheath as well as the increase in the intracranial pressure. So we use a high frequency probe of around 4 to 12 Hertz. And because this allows a better contrast between the nerve and the retrobulbar fat. And after applying the gel over the upper eyelid, the probe is placed and we monitor for the optic nerve sheath diameter. And the optic nerve sheath diameter is ideally taken 3 millimeter behind the eye globe. And it is also said that the optic nerve sheath diameter can also be measured at a point where ophthalmic artery is crossing the optic nerve. We can use the color Doppler to identify the ophthalmic artery, and this also point can be used to measure the optic nerve sheath diameter. And this is an image of using the ultrasound, and we can see the optic nerve, the measurement, which is 3 millimeter from the retinal layer, that is the optic nerve from 3 millimeter. And then there we can measure the optic nerve sheath diameter. Why we consider 3 millimeter posterior to the globe is used, because this is where the optic nerve sheath is widest. It is considered the bulbous portion of the optic nerve, and this is the site where maximum pressure changes occurs. So if you see in the slide, we see the vitreous, then you have the retina, and you have the optic disc, and we have the optic nerve and the optic nerve sheath. So this bulbous part gives us the better, and it is more sensitive to the pressure changes. And there has been study which has been done and published in 2018 in the Intensive Care Medicine Journal, where they have found out that area under the ROC curve is around 0.3, ratio is around 0.93. That means it has got a very high clinical value in terms of correlating the optic nerve sheath to the increase in the intracranial pressure. Now, does it mean that the increase in the optic nerve sheath diameter will always correlate with the increase in the ICP? It is not. So after ICP increases more than 13 to 14 mm of Hg, till up to a certain point, optic nerve sheath diameter will correlate with the increasing ICP. So up till 6.5 mm of optic nerve sheath diameter is where we can see a linear correlation with the increase in the ICP. So after that, the linear correlation between the optic nerve sheath diameter as well as the rise in ICP does not exist. So there has been various studies has been done where the ultrasound probe has been used in the B scan, in the transverse plane as well as in the sagittal plane, and they tried to find out which optic nerve sheath diameter cutoff should be used. And after looking at all the studies, we found out that the 5 millimeter approximately is the best area where we can at least get a sensitivity of 88% and a sensitivity specificity of nearly 90%. Now, there is another way to identify if there is rise in intracranial pressure, that is to looking for the papilledema. So when the fundoscope is not present, we can use the ultrasound itself to identify papilledema. So we can look for the optic disc elevation. So now the point where the optic nerve is entering into the retina, that is the place where it is the optic disc. Here we can see that whenever there is an increase in the raised intracranial pressure, there is reduced perfusion to the retinal ganglion axon cells. And this leads to the leakage of cellular components into the extracellular space of the optic disc, causing an optic disc edema, or you can also call it as the optic disc elevation. And the optic disc elevation more than 1.2 mm is considered as papilloedema. Now we have a patient of idiopathic intracranial hypertension. In these patients also, we can use ultrasound to identify rise in intracranial pressure. So we do something called as the 30-degree test. During this, the probe placement is the same, and the patient is initially asked to fixate a gaze straight ahead, and then the optic nerve sheath is measured both anteriorly and posteriorly, and then the patient gaze is then asked to directed towards 30-degree lateral. So when this 30-degree lateral gaze happens, the optic nerve sheath or the perineural sheath, then it gets stretched, and these after this gets stretched, it is measured again. So if suppose the decrease in the sheath of this diameter is greater than 10% in the lateral gauge compared to the primary gauge, then it is considered a positive test, and it is an indicative of the increased subarachnoid fluid. And you can look for the CSF opening pressure, and then you can also diagnose. So this is one of the non-invasive way to screen for the rise in the idiopathic intracranial hypertension also. So one more way, this is more useful seen in pediatric population, where we can look for the crescent sign. So what is this crescent sign? This crescent sign is seen when there is presence of fluid around the optic nerve, and this gives us a crescent shape or a donut sign. And the accuracy of this crescent sign is very much, to identify this is may not be present in all patients, but once this sign is seen, then the accuracy of that diagnosing papilloedema is more. And this happens mainly because the fluid is collected around the optic nerve. Now, when we measure the optic disc elevation along with the optic nerve sheath diameter, the sensitivity as well as the specificity to identify or to diagnose intracranial pressure increases. And this is more useful when we have an optic nerve sheath diameter of between 5 to 6 mm, where we will err on which side to go. Is it really there is an intracranial pressure, increase in the intracranial pressure, or it is in the normal levels? But when you combine the optic disc elevation as well as the optic nerve sheath diameter, then the chances of your sensitivity as well as specificity in diagnosing intracranial pressure is increased. So if there is an optic disc elevation is there, that means we know that there is papilloedema is present, along with elevation of the optic nerve sheath diameter of more than 5 mm clinches the diagnosis more towards the rise in the intracranial pressure. Now, there is one more thing which needs to be discussed, that there is a chances at times what happens is that there can be an hyalinization at the level of the optic disc, and this can occur due to many causes, and this hyalinization can also cause optic disc elevation. So this is known as pseudopapilloedema, and in this case also combining optic disc elevation as well as the optic nerve sheath diameter helps our cause. So this study has been published in PLOS Medicine Journal, where they have tried to estimate intracranial pressure by using the optic nerve sheath diameter value which we have obtained. The usefulness of this might not be much in accurately detecting it, but then it gives us an estimation of ICP when we know that there is a clear-cut increase in the intracranial pressure. And this will help us to escalate our therapies or to de-escalate our therapies, and this becomes a non-invasive way of estimation of the ICP. So now transcranial Doppler, the ultrasound has also been used to detect the midline shift. So the window we use is the transtemporal window, and there are 3 planes where we can look for the midline shift. One is in the mesencephalic plane, the other one is the diencephalic plane, and then another one is the ventricular plane. The most commonly used one is the diencephalic plane, which we will discuss. So this is the transtemporal window through which the ultrasound is placed, and this is at the level of the diencephalon, that is at the level of the third ventricle. So at this level, the septum pellucidum, the third ventricle, as well as the pineal gland, they all fall in one row. And this constitutes the central portion of the cerebral hemispheres, and this is where it is more sensitive for the midline shift and it is easy to identify. So I'll just tell you how to look for it. So once we place the ultrasound probe in the transtemporal window, then you can in the diencephalic plane, you can see the third ventricle. So you have two parallel lines which are 10 millimeters apart, filled with the CSF. Now this marking of A and this marking of B corresponds to, this is the ipsilateral temporal bone to the third ventricle, and then B marks the contralateral temporal bone to the third ventricle. And the midline shift can be calculated as A minus B divided by 2. This will give us the midline shift, and we know that midline shift of more than 0.5 centimeter is indicative of rise in intracranial pressure, as well as it is clinically significant. Now coming to the transcranial Doppler, recently transcranial Doppler has become very popular in terms of diagnosing not only vasospasm, but also to screen for increase in intracranial pressure, to look for the cerebrovasomotor reserve, and to look for if the autoregulation is good or not, or intact or not. So we'll use the pulsatility index to know if there is increase in the intracranial pressure. So usually the pulsatility index is calculated as the peak middle cerebral artery systolic velocity minus the end diastolic velocity whole divided by the mean velocity. The normal range of pulsatility index falls between 0.5 to 1.2. The value of more than 1.2 of pulsatility index indicates that there is increase in the intracranial pressure. And there has been a formula which has been used to estimate the intracranial pressure using the pulsatility index. That formula is pulsatility index into 10.927 minus 1.284. And higher the pulsatility index means there is reduction in the cerebral perfusion pressure. So pulsatility index and the cerebral perfusion pressure are inversely proportional. And we have tried actually estimating using this formula, and within a change of around plus or minus 3 millimeters of Hg, there is a correlation to the invasive measurement of the ICP also. But when the ICP is in the borderline, this might not be reliable. But when the ICP is definitely elevated beyond a point, then this might be useful in again escalating or de-escalating our therapies. So this is how a transcranial Doppler changes happen when we have an increase in the intracranial pressure. So you can see how this is the normal waveform of the transcranial Doppler and of the middle cerebral artery. And then as the cerebral blood flow to the brain decreases, there is the change in the transcranial Doppler happens. And you can see initially there is a decrease in the diastole, but still the flow is consistent. That is, the anterograde flow to the brain is maintained with the cardiac cycle. Then you have the systolic peaks coming in where the diastolic flow is considerably reduced. But this phase of systolic peaks, we call it the phase 2 in a transcranial Doppler. And this phase 2, still there is a chance that with therapies, the measures to reduce the intracranial pressure, there is some reversibility of ICP can happen. That is, there is a chance that with our therapies, we can try to salvage the patient. And this also has been used as an ancillary test to diagnosis of the brainstem death when conventional methods becomes difficult to use. And that starts with the oscillating flow. So this is all about the the ultrasound, use of the ultrasound and its various applications when we have a patient with increased intracranial pressure.
So I won't say that the transcranial Doppler alone we can diagnose brain death, but definitely we have to do clinical examination and all. It can help us as an ancillary test for diagnosing brain death by using transcranial Doppler when the ICP is very high. Thank you so much, and I'll be happy to take some questions.
Thank you, Dr. Reddy. It was a very nice presentation, and I'm sure you laid the foundation for them to come to the workshop so that they can get a good hands-on experience with regards to TCD, as well as I'm not sure how much of hands-on we can give them for optic nerve, but definitely for TCD, we can definitely. It was a very good presentation. Are
Sorry,
there
I
any
thought
questions?
20 minutes presentation. Later, I came to know it is 30 minutes, so I prepared a few slides.
No, but it was good. It was good. I guess there aren't any more questions. Over to you, Vikrant.
Thank you very much, Dr. K. Subbareddy sir and Dr. Mehul sir. So let's head on to the next lecture. I request Dr. Darshana Rathod to moderate this session. She is the additional director in critical care, and she is one of the most versatile and dynamic intensivists in our department. I welcome Dr. Sachin Gupta sir. He's a senior consultant, Narayan Super Specialty Hospital, Gurgaon. He has completed his American Critical Care Medicine Fellowship and Fellowship of Indian Critical Care Medicine. He has been a great teacher, and I myself have attended his online lectures, and it has been a blessing for all the critical care fellows and trainees who are pursuing the career. So it is a pleasure to have Dr. Sachin sir. I request you to start with the lecture.
Thank you for the kind invite, and I also thank Dr. Rahul Pandit and team for having me here. This is my second edition here. So I'll be sharing the slides. I hope they are visible, right?
Yes, they are visible.
Okay, thank you. So the topic that has been given to me is ultrasound guided procedures in critical care. So see, there are n number of procedures that we do in critical care. And frankly speaking, most of them can be now done under the guidance of ultrasound. So it increases the safety, it increases the precision level as well. And I'll be running through certain important ones here. So we have to understand what do you mean by assistance and what do you mean by guidance. So whenever we talk about any procedure, assistance means you are just going through it, and guidance means somebody is hand holding you and taking you through the entire journey of that procedure. So guidance is an advanced skill, and it's a skill which we always use when we are using and when we are doing any ultrasound guided procedure. So see, assistance means you have seen the venous positioning. So you know, yes, where is my vein located, but then you are not doing the procedure under ultrasound guidance, then it is as equal to a blind procedure. So this is what we call as assistance. Guidance means from needle insertion till the completion, ultrasound is placed on the neck of the patient or on the femoral, whichever venous axis you are targeting, and you see almost all the procedure completely. So when I say echo assisted or echo guided, so assisted means you are doing a preliminary assessment where you are looking what is the target size, what is the location of the vein or the artery or anything else, what are the adjacent structures because you want to avoid damage to the adjacent structures, what is the lumen patency, and you also want to exclude any previous pneumothorax because that doubt should never come that is this pneumothorax because of my procedure. You do this similar examination when you're doing an echo guidance as well or an ultrasound guidance procedure. Then for assisted, you always look for insertion point and direction of the needle. You prepare a sterile field, but the most important thing is you are doing a classic cannulation. So as simple as blind cannulation. So what you do in your traditional landmark technique, where if you have to insert an IJV, you look at the triangle of the sternocleidomastoid and one side is the artery and you puncture at the tip of the of the triangle, but then that is classical technique. So echo assisted means you know where my vein is, but you don't know how the needle is going to traverse and hit that needle. Whereas the echo guidance says you prepare your sterile field, but the procedure is done under ultrasound guidance, which means right from insertion to the skin to the insertion in the vein, you are visualizing the entire path of the needle. And this is what is most important. This is what we practice and preach, that all procedures have to be echo guided and not echo assisted, because echo assisted, again, it varies on multiple things. What is the position of the patient? So once you have assessed the patient and let's say the patient changes the position a little, your assistance is gone now, because the direction or the position that you have thought of is changed. So echo assisted is as equal to as a blind procedure. So when we talk about orientation, so the other thing is there are three words that we use. That is this a transverse orientation? Is this an oblique orientation or a longitudinal orientation? Or if I have to use transverse, I would say is this short axis, oblique is oblique. And if I say long axis, then I'm talking about longitudinal approach. So this is how your vessels would appear in the transverse. There would be two circular structures appearing next to each other, right? One would be rounded pulsatile, the other would be irregular circular collapsing with respiration. So this is how it would change once you are putting the pressure. Then the second one was the oblique, where you see everything as oval, and the third one, what you are seeing is a cylindrical structure, or what we call as an inline approach, or a longitudinal axis, or a long axis, whatever word you want to use it, but your vessel should appear as a cylinder. So if you are puncturing an artery, it should appear as a cylinder. If you are puncturing a vein, it should appear as a cylinder, right? Then in relation to the needle, if you are doing it in a short axis, right, which means the probe is cutting the needle perpendicularly, then you will see a dot on the screen. Now remember, this dot can be anything. I will show this in my future slides, but if you are using a transverse or a short axis, the needle tip would appear as a dot, right? And this is what we call as out of plane approach. Whereas if you're using a longitudinal axis or a long axis, the entire shaft of the needle is visible, and this is what we call as the in plane approach. So these couple of terminologies are important whenever we do any ultrasound guided procedure. So we always say whichever side you're doing the procedure, keep the ultrasound machine on the opposite side, because this makes visualization important. Your positional comfort is very, very important whenever you are doing a procedure, because if you are uncomfortable in standing and whichever way you are standing, then there is a high chance that you will not visualize the needle completely and you will struggle while doing the procedure. So have your comfort at the foremost important thing, and then place your machine on the opposite side of the patient. Orientation should always be in relation to the operator. And as I said, marker positioning and orientation is very important, and this is crucial for the success of the procedure. Then the landmark technique, which is the classical technique, is dangerous, technically difficult, and we always say always do all procedures with the help of ultrasound. Static is the one what I was talking about, is that you have seen a vessel, you have marked something or put a mark, you have gone to wash, and then you have prepared that area in a sterile technique. But if the position of the neck changes a little, when you had marked, the patient was absolutely in an extended position, now he has changed the neck position a little, this mark has gone. There is no value of that marking, and this is as equal to as a classical or a landmark technique. And we always say use dynamic technique, and it could be a 1% or a 2% technique. I'm not going into that theoretical aspect of the procedure. So now let us talk about how to insert lines and what are the prerequisites. So whenever we have to insert any venous access or any vascular access, The linear probe or the vascular probe, as it's famously called, is the one that we use. It's a high resolution probe, 7.5 to 10 megahertz. So it is basically meant for superficial structures, and we understand that all the vascular structures that we want to cannulate are more or less very superficial. So it gives us a very good visualization on the machine. Plus, it has a very small and a thin footprint. So it is easier to keep on areas which are smaller in nature. For example, neck. So it is easier to keep on neck, and it helps us in doing the procedure. Now, this is the previous one. This is how we do the procedures in a sterile way, that we drape the entire probe on a sterile sheet and put a tegaderm over it. But there are camera covers which are available. People are using that camera covers, or people are using gloves as well. The only difference between this and the other technique is that you will have to put some jelly on the probe and then put it in a camera cover, or let's say in a glove, because you need a medium for the ultrasound to pass on. But if you're sticking your tegaderm directly on the probe, you don't require a jelly under the probe, and you can just dip this sterile prepared probe in a cleaning solution, even in saline, and this will give you an excellent visualization. So as I said, there are two approaches. One is the transverse, the other is the longitudinal, and you can use either way depending on the comfort and the expertise that you will have. Now, this is how the transverse view is there. So your probe is and your needle insertions are perpendicular to each other, right? And this is how it would appear. So there are two circular structures that we see on the screen. One obviously has to be the artery, the other has to be the vein. So this pulsatile structure, if you can appreciate, this pulsatile structure, more rounded structure, is the artery, and an irregular circular structure is the venous structure. So this is how your vein and artery would be, and this is a pictorial illustration, and we keep the probe in a perpendicular direction and the needle goes this way. So if I have to put this diagram on the patient, right, this is the subclavian artery and the internal jugular vein. Your vein and the artery would appear as a circular structure, and then you go here and insert the needle, but what you will see is a dot. Remember this. As I said, in a transverse view, you will see a dot. Now, again, this dot is very, very important to understand, because ultrasound does not know what is the tip of the needle. Ultrasound only knows that if any part of my needle comes under my probe in a transverse direction, it should appear as dot on the screen of the ultrasound machine. Now, if you are lucky enough that your tip of the needle is in the vein and your ultrasound beam is also cutting that part, then it appears like this. But remember this, your needle is still inside the vein, but your ultrasound beam is not cutting that part, which means the position, the angle with which the needle has been inserted is not 45 degrees and has been changed. So you will not see any dot on the screen, and you may feel that I have still not entered the vein, and you will fiddle here and there, and probably there is chances that you may harm the surrounding structure, and the most common surrounding structure is the carotid artery. Then, right, this is another thing. You are still seeing the dot on the screen, which is in the vein, but your tip has crossed the vein. Again, the angle of the needle insertion is important. So as I said, transverse view is more difficult. It appears simpler because you see two vessels, so you know where my artery is and where the vein is. But technically, it is a little more difficult because you need to follow the path of the needle. So you need to keep on angulating, and that requires a different level of expertise. It is not meant for people who are starting to use ultrasound, or somebody who knows how to use an ultrasound should start the procedure or should keep the probe, and the other one should do the procedure and help in following the path of the needle, and then these complications are less. This is the biggest problem that I'm talking about, that the shaft is being scanned, it appears as a dot, and the needle has crossed the vein, and you don't know what is lying posterior to the vein. So this is how your IJV transverse view appears, right? And if you can see, the needle is being inserted from the top. The needle is inserted, and this is the tip. So we have followed the path of the needle, and we see that when the tip is being inserted, you see an indentation on the venous wall. If you can appreciate, you see an indentation. The wall is being dipped down, and then you get an insertion. And this is how you should always follow when you're doing a transverse view, right? Then once the needle is in, you put the guide wire, and we always scan the guide wire. The reason is, see, you must have seen sometimes that you have put the guide wire in the IJV, and when the central line has been put and you do an X-ray, you observe that the central line has gone into the subclavian or the otherwise. So what we do is, once you have put the guide wire in the IJV, you just scan the IJV downwards. And if you see a vertical path of the guide wire, then be damn sure that your guide wire is in the correct position and your central line won't go into the subclavian. This is how you scan it. The other way is, you also scan your subclavian on the ipsilateral side, on the same side, and see, is my guide wire visible there or not? If it is visible, gradually withdraw the guide wire till the time you start seeing the J in the IJV, and then again thread it. You need not abandon the procedure or take out the guide wire completely. So these are some tips and tricks that you can follow. This was a way back, very long back. We took this video for completely collapsing IJV in a transverse view, and these are the most difficult ones, how to puncture them. The dynamic technique. In this dynamic technique, if you can see, we are placing the needle in line, in plane with the probe, and this is how it would appear pictorially, that your both venous axes or arterial would appear as a cylinder. If you want to puncture vein, you will just focus on the vein part, and this is how the probe is kept. In the transverse, we were keeping it perpendicular. Here we are keeping in line with the vein, and we will be puncturing at the top. So this appears somewhere like a lateral approach of the classical technique, where we were puncturing it at the lateral head of the sternocleidomastoid. So from a transverse to a long axis, from a transverse to a long axis. See, this was transverse, and we have just rotated the probe, if you can see on the video, and we have converted to a long axis where we see only one vessel. So this is the vessel that we are interested in, right? And this is how the cannulation happens. That again, here the entire shaft of the needle should be visible. So the local infiltration has happened, right? And then after that, we will start seeing the entire shaft of the needle coming in. And once it is about to puncture the venous wall, again, the same indentation of the vessel wall has to be observed, because this tells me that I am not going posteriorly to the vessel, and we will start seeing the needle is about to get entered, right? If you can, yeah. So we can see the entire shaft of the needle, and then we see the indentation. Now, this is the indentation that I am talking about. So what has happened is, you puncture your needle, you see some indentation, and then you see the entire shaft of the needle, and this is how you observe it. Once the needle is in, you pass on the guide wire, and then you complete the procedure. The third is the oblique view. Now, this is a hybrid view where you take the advantages of both the views. You take the advantage of the transverse view as well as the long axis view, which means we try to visualize both the vessels. So both artery and vein is visualized, and we try to put the needle in an inline approach. So I've taken the advantage of the long axis also, and this is meant basically for people who have a little short neck. So this is how the probe is placed, but we insert it in an inline approach. So both the vessels are also visible, and my needle will appear as a complete shaft which is visible there. So this is how it appears. If you can see the vein and the artery, and this is the needle that is appearing. So both the vessels are visualized, and I am in an inline approach. Then this supraclavicular approach, again, for supraclavicular approach, this is how the probe and the position is kept. Again, remember, we always do all procedures in an inline approach. We avoid a short axis approach. So one part of the probe has to be at this supraclavicular notch, the other just parallel to the clavicle, right? And this is how your vein, this is how your venous line, the vein supraclavicular approach would be visible, and we are seeing the entire needle coming in, and the shaft is inside, and then you complete your procedures by just putting the guide wire and so on and so forth. Subclavian axis. Now, this is also very easily we can put it with the help of an ultrasound, but always remember, the distance between the subclavian vein and the pleura is minimal, almost 0.4 to 0.5 centimeters. So never lose the sight of the needle. Whenever you are doing a procedure, always the entire needle should be visible during the entire procedure. The second important point, subclavian should not be inserted in a transverse view, or always in an inline approach it has to be done. right? And this is how we are talking about the infraclavicular approach. So this is what you see, right? Short axis view, where you're seeing one as the artery and the other as the vein, right? So this is the subclavian artery and the subclavian vein just below the vessel. Then you convert gradually into an inline approach where you see the entire needle. Again, the entire vein will appear like a cylindrical structure. So just see, we are converting from a short to a long axis. If you can appreciate both the videos, we have converted from a transverse or a short axis to a long axis where we try to see the entire vein is visible as a cylinder. So this is how you convert from a short axis. First, identify where is my subclavian vein and the artery, and then convert it into the long axis. Similar technique, you put the needle and you see the vessel as an you see the entire shaft of the needle, then you put the guide wire, complete the procedure. This is the central line visible there. And we can also visualize this in short axis. We have differentiated what is the artery and what is the vein. Femoral, again, very, very easy to put. It's a vast area, so much more easier to put. The risk is less. Again, you can put it in the short axis as well as in the long axis. The principles remain the same. PICC line. Now, PICC line is also one of the most commonly practiced procedure, and we generally target either the basilic or the medial cubital vein, right? And say blindly, it is only possible in thin individuals, but patients who are edematous or of morbid obesity or of well-built structures, visualization of veins by naked eye is almost next to impossible. And this is where the ultrasound is useful. And we do a lot of PICC line based procedures, and it is much easier, and it is as simple as putting a central venous line. So see, what has happened is, here we are first identifying from a short axis. We have identified two vessels here. One is the artery, one is the vein, and then I'm gradually converting it to an inline approach where I would be seeing the entire PICC line as the long axis. See, I'm just seeing, and now I'm seeing the vein as a cylinder. And this is what is the basic principle. So if you can appreciate, the needle is about to enter. Again, the indentation is there. If you can see, the indentation of the vessel wall is there, and the needle is gone in just like as the needle has gone in, and right, the needle is there. And then after the needle has passed, you can just continue and put the guide wire, and you see the entire PICC line visualized in the subclavian. The guide wire is there, and this PICC line that we are seeing in this second video is in the subclavian vein, right? We understand that the PICC line will go through the medial cubital and then it goes to the subclavian. So we have confirmed the placement in the subclavian vein as well. We know the pitfalls. You are not identifying the vessel correctly, obviously, then you are bound to have some failure. Risk is through and through venous puncture. So avoid the needle, introduce the needle slowly, always have a real-time visualization, and watch for tenting of the vessel wall. Then this is the complication. I just wanted to show you that although this was done under ultrasound guidance and this was much earlier in our practice, the vein was collapsing, the needle has gone in, but it has hit the artery. And as soon as we realized it, we just withdrew the needle. And if you can appreciate, a big hematoma was created because of this arterial puncture. And even this can happen with visualization. So try to understand what happens when you're doing this procedure blindly. And the commonest thing that you see is you have inserted the needle, you don't get a blood flow. And then as slowly, gradually you're withdrawing the needle, you get a gush of the blood and you say, fine, I have punctured my vein, but you don't know what else have you punctured, at least in a blind procedure. So ultrasound is the modality with which all venous accesses or an arterial access should be inserted. And even peripheral venous cannulations can be done with the help. The other thing is, the next procedure that I would be talking about is endotracheal tube in placement. So whenever we are doing an intubation, we are looking at two important aspects. I always say, which tube have you intubated? Is it the trachea or the esophagus? And once you say I've intubated the trachea, then the next question is it one lung in ventilation? So which means, is it an endobronchial or is it a bilateral ventilation? So we can easily observe while somebody is intubating this patient. So this probe has been kept at the level of the suprasternal notch on the left side. So this structure is the trachea, where we see thyroid gland and the isthmus and the tracheal rings here. And while somebody is intubating the trachea, we can see disturbance happening at the tracheal level. So we correctly know that somebody is inserting the trachea. That is the answer to the first question. Which tube have you inserted, esophagus or trachea? But suppose you have done an esophageal intubation. See, ultrasound doesn't know what is trachea and what is esophagus. Ultrasound knows that if there is a tubular structure which is filled with air, it should appear like this, like trachea. So once you have intubated the esophagus, the ultrasound will show a similar structure like trachea, although smaller in size, and we call this as a pseudotrachea or a double trachea sign. The moment you withdraw the tube, esophagus is a collapsed structure. It will collapse completely and you won't see a trachea. So here, just by keeping the probe, you can say that, yes, my dear friend, you are intubating the esophagus and not the trachea, and the procedure can be, converted to a tracheal intubation then and there itself, rather than inserting in a noisy environment, then looking for 5-point auscultation or capnography. I am not asking you to remove capnography from, that's the gold standard, that has to say, but this is again a visual equity which everybody can then and there itself comment on. Once you have intubated the correct tube, then the next question, is it a one lung intubation or is it a bilateral intubation? So what we call here as the lung pulse, which means, if you can appreciate this image, this is, the lung is not sliding, it is just stagnant on one point and it is pulsating, which means with every cardiac pulsation, the lung is stagnant there, and we call this as the lung pulse or an immobile lung, which means if this has happened during intubation, then this part of the lung is not getting ventilated. This could be the left or the right, or this can also happen if there is a local lung collapse or patients have mucus plugs. So this is the finding that you can have. Even in apnea, the patient can have an immobile lung, and this is what we name as an endobronchial intubation. The Ryle's tube insertion, yes, in unconscious patients or patients whose mouth are very clenched, they are not allowing you to open, or it's a blind procedure. You can easily visualize by keeping the probe on an esophagus that once the Ryle's tube is inserted, and you can appreciate here what is happening. And the prandial status, so this was for one of our patients who had an upper GI bleed. And if you can appreciate, in the first video, we were aspirating it through the Ryle's tube, and we can see the aspiration movements. And once the entire aspirate was done, we can see the Ryle's tube in the stomach itself. So you can easily confirm this in areas in ICUs where you see a lot of GI bleeds. The Sengstick and Blackmore tube is inserted. I know it's more or less an obsolete now, but if you still have it, and if you're still using it, if you're just inflating the balloon, you can see a hemispheric balloon inside the stomach because it is filled with air. So you can just see the upper surface, not the lower surface. So that is also another way of confirming the correct placement of Sengstick and Blackmore tube in the stomach. Then tracheostomy, we do this procedure day in and day out. I'm not going into any theoretical aspect here. So tracheostomy has to be done in the short axis. So what we see here is this black line. This is an indentation of the needle which is going in, and we see that we have tried to avoid the isthmus, and this is one of the tracheal rings where we are inserting. Once you have inserted the needle, you pass on your guide wire, and once you pass on this guide wire, we convert the probe to a long axis to visualize from which tracheal ring the guide wire has passed. So this part is the cricoid. This is the first tracheal ring, then the second tracheal ring. So our guide wire has passed between the second and the third tracheal ring. Now these are difficult anatomy patients. So now this was for one of our patients where we were planning to do a tracheostomy. When we scanned, we could see so many blood vessels in the path of the needle. Now try to understand if this procedure was done blindly or even under bronchoscopic guidance. See, bronchoscopy tells you only about the lumen of the trachea. It does not tell you what is there in the path of the needle before you hit the lumen of the trachea. And this is where ultrasound comes into the picture, where it tells you what is there in the path. You can avoid these vessels completely. And what we do for such patients is we try to follow the principle of liposuction. So we create a pseudo space by just infiltrating local anesthesia there, and we try to separate the planes, and we try to divert these vessels far apart from each other so that you can put your needle and your dilators and everything, and these vessels are not ruptured. So this is how we do it, and we follow the same principle as what happens in liposuction, that you are creating pseudo spaces and pseudo fat spaces for liposuction, and this is the same principle that we apply here. Then Lung recruitment. I know lung recruitment literature says don't do it, but everybody does it. I would put it this way. I'm not denying it. So if this is a collapsed lung, completely collapsed lung, now can it be re-aerated? So yes, ultrasound can help you in understanding and tell you, is this a collapsed and an atelectatic lung, or this is a completely pneumonatic lung, and where these lung recruitments are not going to happen. So we attempted one of the lung recruitment techniques, and we could see that now the lung which was appearing like liver is not so, and we could see a lot of B lines appearing. This was after 10 hours, and we could see that entire B lines and entire pleura has started sliding. So which tells us that slowly, gradually, the lung has come into the picture, and it is taking part in ventilation. And after 24 hours, almost the entire lung was ventilated. So this is how you can actually gauge what level of recruitment has happened with whatever techniques you have done. And if I have to sequentially show you from a collapsed lung to 24 hours after this, then pleural effusion, and there are various signs of calculating pleural effusions and presence of pleural effusions, but this is how we do it, by just keeping the probe at the level. And what we see is we try to avoid the rib. First you see the ribs, and then we try to keep it between the rib space, and this is the CP angle, the diaphragm that we see. So we call this as the costophrenic angle, and we are not seeing any rib space. So the needle insertion becomes much safer. And again, once we see the space, again an inline approach is being followed. So that's the basic principle. We see the entire needle shaft going in, and if you can appreciate, the needle is just about to be entered. Once the needle is there, you just insert your guide wire, and we generally prefer a single lumen line to be inserted, which helps in drainages. And this is how we do pleural tappings and ascitic tapping. So again, no static technique to be followed. Similar principles to be followed for ascitic tapping. And again, if you can see, the needle is inserted, and then you insert your guide wire, and the drain is in place. This is the guide wire in, and then you insert your drain. This is the liver abscess. Again, the similar principle is followed, but always remember, once you are doing a liver abscess, there are a couple of things that have to be taken in mind very clearly. What is the location of the liver abscess? Now, if you can see this abscess, this was just subcapsular under the diaphragm, and you can also see there is a lot of pleural effusion. I don't see any lung here. So if this is the scenario, so there are a couple of scenarios whenever liver abscess drainages come into the picture. So if this is the scenario, don't drain pleural effusion first, because if you drain pleural effusion, your lung will expand completely, and then it becomes a little tricky and little unsafe, because then this liver abscess is very close to the diaphragm. So you don't want to create a pneumothorax or a risk of pneumothorax. So here, the first drainage that has to happen is of the liver abscess. And if you also want to drain the pleural, then it becomes second. If you're not draining pleural, very good. But if you also want to drain the pleural fluid, then that is the second fluid you will drain. Second important thing is, whenever you are draining liver abscess, always put color Doppler time and again during the entire procedure till the time your needle is in the abscess, because there are very, very small vessels which will vary with the phases of respiration. They can't be visualized by naked eye. So always put color Doppler again and again unless and until you are entering the liver abscess. So this is how the abscess would appear on, and this is, we have done it on a linear probe, right? So again, the color Doppler was put in to see what is the location of the various vessels, so that you can know from where will I enter and how can I avoid these vessels. So if you can appreciate, the needle is coming in, and again an inline approach. I want to see this entire needle. I don't want to be on a short axis. And if you can see, we are just entering through the diaphragm. Again, the pinching, and this pleural effusion is causing a little difficulty in pinching of the diaphragm, but that is acceptable because we don't want the lung to be there. Once understand, if the lung is there, then it becomes very, very difficult to go through, right? So the needle is here, and we would just advance, and once we advance, we would be in the cavity itself. This is where we are. We have inserted the guide wire, and once the guide wire is there, you can see this is the pigtail catheter. The double shadow of the pigtail catheter is there. And once the liver abscess has been drained completely, Then you look at the lung and you can see that the liver abscess, the pigtail catheter is there in the liver abscess and the lung is still collapsed. Then last is pericardiocentesis. There is a difference between how a cardiologist does and how we do. We always prefer the area where there is least distance to the pericardium, and we generally do it from the parasternal axis, right? So if you can see, this is the video of a patient who has large, massive pericardial effusion leading to tamponade. This is a subcostal view, and then again we convert it to a linear view, and again an inline approach. And if you can appreciate at the top, we are seeing the pleural sliding happening. So we want to avoid, we don't want to create a pneumothorax. And what this is the heart which is moving, and this all anechoic or blackish shadow is the fluid around the heart. So we see the needle from the top coming in. Once the needle is in, you just insert your guide wire and you complete the procedure. Thank you so much.